Welcome everyone. This is the first episode of what we call the Chat with Experts, and I couldn't have a better colleague here to introduce for the first one, Dr. Jai Cegla, my colleague at Imperial College London. She's a specialist in cholesterol, she's a specialist in lipids, and she in fact has a few positions in the UK, and that's one of the reasons why I have chosen her to be my first guest. She's a medical advisor for the Heart UK, which is the largest cholesterol charity for patients in the UK. And she's also on the clinical advisory group for lipids and cholesterol for the NHS England. And of course, she's a very good communicator. And that's why I'm here today discussing this very important matter for patients, which is high cholesterol. So let me introduce to you first, Jay. Thank you very much, Jay, for joining me. And I think we should go straight to the first question, which is perhaps the very basic one. And I'm asking you to explain this in very lay terms for people. So what is cholesterol? What are the molecules that people talk about? Are they good? Are they bad? What's their role in our body? And when they start causing problems to us as individuals?
Hi, Ricardo. Thank you so much for having me. And it's a real pleasure to talk about cholesterol, which, as you know, is a topic that's quite close to my heart, excuse the pun. But let's, as you say, let's talk about the sort of the basics first. So what is cholesterol? And I think, you know, we all know that cholesterol is something that we need. It's you know, Mother Nature wouldn't have kept cholesterol in our bodies if it wasn't there for a specific role. And the main three things that we need cholesterol for are firstly to package our cells in. So we have membranes around all of our cells in our body, and cholesterol plays a really, really important part of that. The second thing is in hormones. So there are certain hormones that are based on cholesterol, such as some of our reproductive hormones, like estrogen, testosterone. For some of our vitamins, like vitamin D, so cholesterol is again really important in producing vitamins, vitamin D, and keeping our bones and our teeth healthy. And then thirdly, in terms of bile salts, so we have these things called bile salts that are made of cholesterol, and they help us digest fat from our diet. So cholesterol is really, really important, and we need it to function as healthy human beings. I guess the problem happens when cholesterol becomes too high, okay? So, you know, we need a basic level of cholesterol in our bodies, but when it gets too much, that's when problems arise. And if you don't mind, Ricardo, I've got a couple of slides I'd like to share, if that's all right.
Excellent, perfect, go ahead.
Just to explain this in a little bit more detail. So here we go. So I've kept this really, really simple, but we think of this as the good and the bad in terms of cholesterol. So cholesterol doesn't just float around in our body through the bloodstream. It's packaged in these sort of parcels, which we call lipoproteins. And there are two main lipoproteins that I want to focus on here. So there's the LDL, the low density lipoprotein, and the HDL, the high density one. And we often think about low density lipoproteins as the ones that carry bad cholesterol. And that's because what happens is the LDL cholesterol basically comes from the liver and takes cholesterol to all the cells, okay? And when it gets too much, that can cause problems, and that can cause blockages and clogging of the arteries. And the HDL, the high density lipoproteins, are what we call carrying the good cholesterol. And these ones take the cholesterol from the peripheral tissues, from the cells, back to the liver to be removed. And as I said, you know, it's all about balance between the good and the bad. And when we have too much of this bad cholesterol, we can get clogging of the arteries. So here on the left, you can see a normal artery, and you can see the blood coming through nicely there. If we have too much of this bad cholesterol, the LDL, what can happen is that it can slowly infiltrate this arterial wall, okay? And so firstly, you get this sort of fatty streak, and then you get more and more fat depositing in there. And the wall doesn't like this fat in there. It gets really angry and inflamed. And occasionally what can happen when there's too much fat there, it can cause narrowing, and occasionally it can burst. and that's when you can get a heart attack or a stroke. And so that's the sort of the basics of good and bad cholesterol. We can go into a bit more detail if you like.
No, I have two questions on that one. First of all, you presented two of them, the LDL and the HDL. But when you get blood results back, patients will see there are some other items there, including triglycerides or VLDL or some other names that are complicated. So is there anything else that people should know in a very summarized way that they should be concerned about?
Yeah, no, it's a really good point. So these lipoproteins, they contain mostly cholesterol and triglycerides, okay? And as I said, so the HDL is mostly cholesterol, and its job is taking this, this cholesterol back from the tissues into the liver. The LDL is made up of triglycerides and cholesterol. And then there are other lipoproteins like VLDL, chylomicrons, which are mostly triglyceride rich. And triglycerides are just basically another type of blood fat. They can be a problem as well for the arteries when they get too high. But what we often think of is the bad cholesterol, the LDL, with these other chylomicrons and VLDL. We call them together, we can call them non-HDL cholesterol. And that in its own right can be bad when it gets too high.
And surely they interact with other problems as well, because as we know, it's not just the high cholesterol that is causing heart disease around the world. There's the diabetes, there's smoking. So how do they interact to finally cause heart problems to people, Jay?
Yeah, so there's a mixture of kind of genetic things. So, you know, the genes that we're born with compare with the lifestyles that we lead. And often, you know, if we have genes that make us more predisposed to kind of diabetes and things, that can make us more insulin resistant. And that makes us more likely to produce these non-HDL types of cholesterol, so the VLDL, the LDL cholesterols. And again, that then makes us more predisposed to having arteries getting clogged. And that's why diabetes is a risk factor for arterial disease as well.
I see. Perfect. Thank you, Jay. And now we all take this information for granted. We know about cholesterol. We can tell our patients. But tell us a little bit about the history behind it. When did we first found out that cholesterol was a problem, and what is the evidence behind this amount of data that we have that we claim that cholesterol is a bad thing for patients?
Yeah, I mean, I think that this link between cholesterol and heart disease, it goes back a long time. It goes back over 100 years, probably back to Russia, to a chap called Anishkov. And he's often thought about, he was actually a pathologist, and he looked at the effect of dietary cholesterol on the arteries. And he did quite a lot of experiments feeding initially rabbits with high cholesterol diets, and then looking at the arteries and seeing how much kind of fatty streak there was. And he sort of was, we think of him as the sort of the father of atherosclerosis, and he's very famous for a quote that he wrote saying that there is no atherosclerosis, no clogging of the arteries without cholesterol. So that was really, really important, his work. But since then, you know, there have been lots and lots of different types of studies that have kind of helped us concrete this link and cement this link as scientists and as doctors. So there's three main things that I think of, and that's not just to do with cholesterol, but, you know, if we were looking at the link between other diseases, for example, for blood pressure and hypertension, or between obesity and diabetes, you want to have really, really good evidence before you make that link, not just as an association, but, you know, that it's causal. And so in terms of cholesterol, I think the first kind of piece of evidence that we think of is what we call epidemiology. So it's an association between the levels of cholesterol in the population and the risk of heart disease. And there's been a lot of epidemiological studies that have confirmed that the higher the cholesterol in general, the higher the risk of cardiovascular disease. I guess the second piece of evidence that we think about is in very extreme levels of cholesterol. So in people who have genetic diseases, such as familial hypercholesterolemia, These people are often born with very, very high cholesterol levels, so they carry them throughout their lifetime. And these patients often will have very premature, very early onset heart disease, often in their 20s or 30s. And the converse is true too. So if you've got people who have genetically very low cholesterol levels, often they're protected from heart disease. So that tells us, that's kind of gives us a genetic type of evidence for this association between cholesterol and heart disease. And then I guess the third one, which is probably the most important one, is looking at clinical trials and showing that if you can reduce cholesterol, you can also reduce the risk of heart disease. And we were able to do that initially, before we had really good drugs to do this. We in the 1970s at Hammersmith Hospital, actually, we developed a technique called plasma exchange, where we were, in people who had very high cholesterol, we were able to remove it using like a dialysis type procedure. And in these patients, we were able to also halt some of their atherosclerosis, some of the clogging of the arteries as well. After that, some of the first medicines, the statins, came about to try and lower cholesterol. And over the last 30, 40 years or so, there have been numerous trials that have shown us that if we lower cholesterol using these medicines, we're also able to reduce the risk of heart attacks and stroke. And that's in people who've not had a heart attack or a stroke previously, and also in people who have.
So pretty compelling evidence, Jay, there, especially for us who are living with this condition in our day-to-day life. So all the institutions, all the serious institutions, universities, government bodies recommend and clearly demonstrate the link between the two. So why is that there is so much media behind perhaps this conspiracy theory claiming that there is no link between high cholesterol and heart disease? There are many books written about it. They're very popular. And that somehow influences people's opinion. And for the lay people out there, they don't know whether to trust me or you, or to trust this other opinions from people who claim the opposite of what you're saying. So with them in mind, what would you tell them without trying to be too judgmental on their position? Why do you think there is such a myth out there that perhaps cholesterol is not such a bad thing?
Yeah, I mean, I completely agree. It can be quite a tricky thing to navigate, especially if you do this by Google or, and try and look at the media coverage out there. I mean, in terms of the medicines, the statins, they are, the most widely prescribed agents. They've also been the most well studied in terms of clinical trials. I think the evidence, as a scientist is out there, it's very compelling. But I think the difficulty arises for patients, because it's a really tricky thing, isn't it? A doctor does a blood test, they give you a result, they tell you, you've got this high cholesterol and you need to now take a medicine for the rest of your life. And that is difficult because, you feel absolutely fine. And the idea of having to take a medicine when you feel absolutely fine can be quite a hard thing to accept. And I think what we have to do as doctors is really kind of explain the fact that, this is all about risk and about graduated risk. Some people are at much higher risk, some people are at lower risk, and it's working out partly on an individual basis where your risk threshold is, where you feel comfortable to actually do something about the risk and take a medicine to try and mitigate that risk. Yeah. And that threshold will probably be different for different people, but it has to be a kind of conversation that you have to have with your doctor. Yeah. And at the end of the day, I think there are people who want to sort of do more natural things, to talk about lifestyle, and those are really, really important. Lifestyle is so important in keeping yourself healthy. But for some people that may not be enough, and you may need that extra help with medicines as well.
So Jay, linking this very final point that you've made to the blood test that people will get, is there a normal value for cholesterol? Or is it something that we should look as a number? So what would you say to people? I know it's very difficult to talk about in details, but as a rough guide, what would you tell and explain as a normal cholesterol level?
Yeah, so as you say, there's no one right number for everyone. But in general, we would say that, you know, having a total cholesterol of less than 5 millimoles per litre, which is around 190 milligrams per deciliter, would be reasonable. Obviously, if you've got someone who has a history of very premature cardiovascular disease in the family, then you would be aiming for a lower level. And equally, if someone's already had a heart attack or stroke, again, you would be aiming much, much lower, potentially around 1.8 millimoles per litre or 70 milligrams per deciliter, or even lower than that.
Is there any danger in lowering too much? We hear this sometimes, people getting worried about, oh, my cholesterol is too low. Is there any problem with that?
Yeah, that's a really good question. It's only really been in recent years that we've been able to lower cholesterol to much, much lower levels. And there have been sort of studies looking at the safety data on this. And in terms of looking at the reproductive hormones, vitamin levels, all of these things, there doesn't seem to be any negative impact. So there doesn't seem to be a threshold at which you need to be worried. And certainly it appears it's a sort of straight line. If you look at the graphs, the lower you get that LDL cholesterol, the better you are doing for your coronary artery.
Well, I remember you explained this to me once, Jay, in a clinical conversation, that some families, some people were born with no HDL circulating. And surely if that was a problem, they would have multiple problems in their lifetime associated with a low LDL cholesterol. And it doesn't seem to be the case. Is that right?
Yeah, so again, low LDL cholesterol, these families, it's quite remarkable. I mean, they seem to live into their 80s or 90s and they do extremely well. So, you know, it doesn't seem to be an issue. And that's why I think patients often say to me, gosh, you know, the goalposts have changed. My target cholesterol has really, over the years, you know, you wanted it to get to this and now you want to get it to this. And actually, it's because we're doing better and we've got more medicines available to us to lower the cholesterol further. And we're finding as we do that, actually we're reducing their risk of further disease much better. So actually the lower the better. Excellent. For sure.
Okay, thanks, Jay. That's been excellent so far. So now we have a problem. The patients who get their blood tests back and they say you have high cholesterol, whether or not it's too high or a little bit high, they were told they need to make it lower. So first of all, without going into the drug therapy and the statins, which we'll talk about a bit later, what can people do in general to lower their cholesterol with lifestyle modification? I know, again, if you go to Google, you're gonna read a lot about it. And for general people to know how to screen what is true and what is not true is quite difficult sometimes. So what is the evidence behind lifestyle modification? What can people really achieve in terms of lowering their cholesterol by changing their lifestyle?
So I think it really depends what your lifestyle starts as, what the benchmark is. So, you know, if you've got a patient who's extremely obese, who is eating fast food every day, who is smoking, I think you're going to have a hell of an impact. You'll really improve things if you change lifestyle. But if you've got someone who's already quite reasonably active and they, you know, their diet is also okay, then actually changing lifestyle isn't going to have much of an impact on their cholesterol levels. And remember, you know, 80% of your cholesterol is made by the liver and only 20% comes from the diet, right? And even that from the diet, between patients, there's huge variability in how much cholesterol you absorb. So some people we think of as hyperabsorbers, okay? And some people don't absorb much from their diet. So in those patients who are hyperabsorbers of cholesterol, they're more likely to have more impact by modifying their diet. So I think it really, really depends on where you start with your diet and your lifestyle. So you could have, you know, really, really good improvement if your diet is terrible from start. But for most patients, I try and kind of keep this, be quite realistic with them that, yeah, it's going to be important, but it's not necessarily going to change everything. And often patients are really, really disappointed because they'll have made huge, huge efforts with their diet. And then 3 months later, their cholesterol hasn't budged. Complex. So to keep it simple, in terms of the diet, you want to make sure that you're getting, you're reducing the amount of red meat in the diet. You're getting in plenty of fresh fruit and vegetables, trying to keep the amount of carbohydrate in there limited as well. And making it not too radical, because it's then unsustainable. You want something that you will be able to keep going year on, year out, and keep as part of your normal diet, rather than do something that you do for a couple of weeks and then go back to your old habits.
Correct. And I suspect the diet in this case it has multiple roles, not only in lowering cholesterol, but if you're overweight, you're going to likely have diabetes and high blood pressure. So
Exactly.
losing weight in a healthy diet is like there are multiple benefits of doing so, and one of them, of course, is lowering your cholesterol. So that was a very good point. Now, moving on to a bit more controversial waters here, is when people are told they need to take a statin or pills to lower their cholesterol. And I know that, again, we're going to repeat this. There is a lot of evidence behind and to support their use and how good they are for patients, particularly with very high cholesterol and heart disease. But what is your feeling on talking to patients out there? And why do you think there is this, again, myth behind the danger of statins or how untolerated they are by patients?
I think, part of this is that, drugs evolve over time, and, those first generation statins, even though that they had, were proven to reduce the risk of heart attacks and strokes, they weren't as clean and, as good as some of the newer medicines that we have, which are now much better at lowering cholesterol, but without some of the side effects that were seen with some of the earlier statins. And the one that we often come across is muscle symptoms. So with the newer statins, this is much, much less of a problem. And if you look at clinical trials and you look at the active arm, so the patients who had the active drug versus the placebo, the dummy drug, the levels of these symptoms are very often similar in both groups. We just did a study actually here at Imperial, because we do see a lot of patients who say that they feel these symptoms, have these muscle related symptoms, and it's often very hard to know, is it actually the statin that's causing the symptom, or is it just just your daily life and aches and pains that we get with our daily lives? And separating the two out can be very tricky, especially if you've already been forewarned that the statin is likely to cause you problems. Because we're humans and we have this unconscious bias there. So we did this trial called the STATINS study. I don't know if you came across it, Ricardo, but we basically gave some of our patients who had some symptoms after taking a statin as part of their normal treatment. And what we did was we either gave them a atorvastatin or a placebo, or no medicine at all. And they had a month of each of these. We did this then for 12 months in total. And it was really nice because patients were able to see for themselves whether it was the statin causing the symptom or whether it was the symptoms were still there with the placebo. And for the majority of patients, actually, they had the same symptomology with the placebo as they did with the statin. And it was really useful for people to see, oh, okay, actually, it isn't the statin causing my symptoms. And they were able to then start it with the knowledge and the reassurance that the statin wasn't causing a problem for them.
Yeah, it was an excellent try. In fact, I put them on my social media on the day of when it was published because it's such a high impactful piece of data that just shows that I know medications can have placebo effects, but as you call on the paper, it's called a nocebo effect. Yeah, and the side effects can also be placebo. And to the defense of the patients, being told you have a problem, you're reaching that age that there's a lot of aches and pains everywhere, and you have to take a pill every day. So that process itself causes side effects rather than statins. But having said that, being a bit more rational about it, there is a lot of problems by creating a myth behind such important group of medications, which is the statins, because a lot of people out there are generally scared of taking, not just because of side effects, but because they really can cause cancer, dementia, diabetes. And I think it's our role as an educator, and particularly in your subspecialty, Jay, that we have to teach these people very confidently that statins will not cause them problem. If anything, they were prescribed to them to lower the risk of having heart problems.
Yeah, I agree. I mean, it's a really important role for for us as physicians, we have a responsibility to make sure our patients are making informed choices about these medicines. And yeah, with the internet, often there is a lot of misinformation about this. But I think in terms of the data on statins, we've had these medicines around for 30 years or more. We've got really, really good safety data and efficacy data. So, certainly, when the way I always approach a patient in the same way as thinking, how would I treat my mum with this condition? And I think we have to be very, very comfortable with this medicine, and I think we are. It's just now really informing patients about the scientific data surrounding it.
Excellent. So moving on from the statins, Jay, and I know that in the past there have been many other drugs that attempted to lower cholesterol, some of them successfully, some of them not many of them with good trial data, with hard outcome data, as we call. But how about the future? What is coming next? One of the problems of the statins, of course, is that people have to take the drug every day, but there are some new medications that perhaps can be injected every few weeks, every few months. So what is on the horizon for patients with high cholesterol that maybe will make their life easier?
So it's been quite an exciting time in the lipid field and cholesterol field for us in the last few years, and we've had some new medicines available to us within the last 5 years called the PCSK9 inhibitors, and these are alirocumab and evolocumab. And they're basically every 2 weeks, you take an injection just under the skin. Patients can do this themselves. It's like a pen, you can't even see the needle. And basically what this does is increase the clearance of LDL cholesterol from the liver. And these drugs have been really, really quite potent, quite good at lowering LDL cholesterol. They lower it by about 50%. And more importantly, they've been shown to actually reduce our patients' risk of heart attack and stroke, which is really obviously the end game. So that's been a really, really big advancement for us. And then more recently, in the last year, a drug called inclisiran has become available. And this is a 6-monthly injection, again, for lowering LDL cholesterol. The data that we have so far is really, really promising, but there are still ongoing trials to look for outcome data in terms of whether we can reduce heart attacks and strokes with this medicine, and also longer term safety data. So I think it's watch this space for inclisiran, but really, really promising.
But these pills are not necessarily available, these injections are not necessarily available to everyone immediately, because not only, as you said, they are not as well tested as the statins on the long term, but also they must be exponentially more expensive considering injections in new drugs in the market. Is that right?
So I think at the moment in the UK, they've been approved for people who've had previous heart attacks and strokes and people who've got quite high LDL cholesterol levels. So usually with new medicines, you look at people who are going to benefit most from them, and that's who they're usually first licensed in. So that's the group of patients who will firstly have them available. But I guess as more and more safety data comes out, more efficacy data comes out, then the thresholds may change. And obviously, yeah, cost comes into it, as it always does, sadly.
But if all goes to plan, perhaps in a decade or so, you're going to be talking about, for most patients with high risk, having injections every 6 months would be the equivalent of taking a statin every day today, if all goes as the data so far has shown.
Potentially, yes. Yeah, I think we just need to watch the space, and yeah, you do want to have, before you roll things out very widely, you do want to have really, really good safety data too.
Brilliant. Jay, it was a pleasure talking to you. Now, finally, I'll leave you the space now to give a final message to patients and summarize what you think is important about cholesterol, and in a more pragmatic way, what they should do, say if they have found to have high cholesterol, whether they should talk to their doctors, read about it. I'm going to put a few links here in the bottom of the video of websites in the UK and the US that you can reliably read about high cholesterol. What will be your final message to them, Jay?
Yeah, I think, cholesterol is one of those funny things where you feel fine, and often the effects of it often will come too late, after a heart attack or stroke. And so I think, if you have been found to have high cholesterol levels, be proactive about it, get the right information from the right sources, talk to your doctor, and potentially have treatment to protect yourself.
Excellent. Good final message. We see a lot of patients, cardiologists, coming with heart problems, and they knew their family had heart problems in the past, and all caused by a high cholesterol. So do go and check, and don't feel embarrassed to ask your doctor about this and be checked on, because prevention, as always, is the best way forward, particularly with that as a silent killer, as we often call Jay. Thanks so much, and I hope everyone has enjoyed. There will be a few links in the bottom of this video here for people to get more information. And I hope you can also join me next time when I talk to another expert on their fields, talking to you for you to understand a bit more about your condition, and hope you get the best available treatment for what you're wishing for, and get information from us here as well. Many thanks, Jay.
Bye.